disadvantages. All right, so what are fibroids? Most of you probably know that fibroids are very, very common. They affect 80% of women. They cause various symptoms, but some patients will say, I don't have any symptoms, right? But typical symptoms include pain, abnormal bleeding, which can lead to anemia or low blood count, bladder and bowel symptoms like frequent urination, constipation, can be lower back pain, or it could be infertility. What is the issue with delay in care, right? So what happens if you don't do anything about your fibroids? Well, they get bigger, and then they can have a major impact on your health, such as worsening anemia, blood transfusions, hospitalizations, or they can have a permanent impact on fertility. All right, so the common treatment options, and we're talking about procedures rather than like birth control pills, because those are really not fibroid treatments. Those are just treatment of abnormal bleeding, right? So you're sort of, if you have a tumor in your head and you have a headache, yes, you're taking Tylenol for the headache, but you're not actually addressing the tumor. So birth control pills and fibroids aren't really, birth control pills are not treatment for fibroids. You're just potentially treating some of the pain or abnormal bleeding that's being caused by the fibroids. But the treatment options for fibroids are uterine fibroid embolization, myomectomy, which is just a general term for fibroid removal surgery. It could be any type of myomectomy. It could be invasive or minimally invasive. Then there's radiofrequency ablation, or RFA, also known as a SESA procedure. And then there's hysterectomy. So we're going to focus on the top two because they frequently come up, and often patients who are looking for myomectomy are given the option of embolization. And I think it's important that patients understand the difference and advantages and disadvantages of both. So what is UFE, uterine fibroid embolization? How does it work? So it's a procedure that's performed by interventional radiologists, and it's what we would call a minimally invasive procedure. Small particles are injected into the blood supply that leads to the fibroids. And the idea is that if we block the blood flow to the fibroids, that we can stop these fibroids from growing and potentially even cause them to shrink. This is done through either a vessel in the groin or in the wrist. It's outpatient procedure. It doesn't take effect immediately because as these fibroids blood flow decreases, with time they start to what's called degenerate or die off. And again, typically do not grow any longer and sometimes can decrease in size. So that's kind of the idea behind this procedure. What's the issue? It's really not for patients who want to conceive, right? Because think of it this way. Here's your fibroids. Let's say this little picture here with two fibroids sitting there. And where pregnancy would take place is inside the space. And the fibroids are sort of squishing the uterine cavity, which is where implantation takes place from both ends. So the embolization does not remove the fibroids, right? So if these fibroids are impacting implantation or impacting fertility, they're still going to be impacting fertility in the same way after the embolization. Another issue is that up to 37% of patients will have decrease in ovarian function. So ovaries are, what produce eggs, right? So we know that we're born with the number of eggs that we have, and then as we age, the number of eggs decline. The ovaries also produce hormones, and those hormones is what helps someone get pregnant. So as we age, the level of hormones decreases. Well, the embolization can affect the blood flow to the ovaries, which can lead to decrease in the hormone production. So someone who is young, who undergoes uterine fibroid embolization, may have decline in the ability to get pregnant because of the ovarian function. Again, I already said fibroids do not go away, right? So if you have symptoms from these fibroids like frequent urination, or if your fibroids are really big and your belly is sticking out, embolization is really not going to do much for that. All right. So if you have a fibroid the size of a watermelon, and you have embolization, most likely 2 years later, it's still going to be the size of a watermelon, okay? So it won't be a size of a, I don't know, beach ball, but still watermelon, right? So if you're trying to get rid of the large fibroids, embolization is really not for you. Who it's for? Someone who has maybe small to medium-sized fibroids, who doesn't want fertility, who might have some heavy bleeding. So that, but again, not desiring fertility. So then in that case, most likely they're going to be they will benefit from embolization. However, new fibroids can still grow, right? So it does not eliminate their chance of having new fibroids and having new issues in the future. So just really important to keep in mind, because this procedure is highly marketed. So, you know, and odds are if you have fibroids, your OBGYN or one of your doctors have probably mentioned it as an option. So this is sort of, again, saying the same thing, but can embolization affect fertility? Yes, right? So higher miscarriage rates because you're not actually removing fibroids. So if there are fibroids near or in the uterine cavity, you're going to have a miscarriage, and the embolization is not going to stop you from doing it. Ovarian dysfunction, right? So decrease in blood flow to the ovaries. You may sort of have menopausal level hormone production, and that's definitely not helpful for fertility. But even if you're not interested in fertility, it may mean that you may go into menopause sooner than expected. Implantation. So again, if the fibroids are in the cavity or near the cavity, that's going to either block the fallopian tubes or impact pregnancy. And again, embolization is not helping with that. Pregnancy complications. Again, fibroids can cause growth and can affect the growth of the placenta, which is where the fetus gets blood supply. It can affect the location of the placenta, can affect the growth of the baby, can cause breech presentation, which is, you know, upside down, can lead to preterm labor, risk of prolonged labor, you know, all these different things that, again, embolization is not addressing. So if you have fibroids and you want to get pregnant in the future, doing embolization is a completely wrong procedure to do. But sorry to go back, when you go for a consultation, I am, you know, 99% sure you will be told, well, it's fine to get pregnant after embolization, and there are patients that have gotten pregnant after embolization, but that's not the same thing as saying it's safe, right? Or we recommend this procedure because you want to get pregnant. So that's a big difference. So you have to, again, just advocate for yourself and ask very specific questions. The alternative to embolization is myomectomy, okay? But myomectomy is, again, it's just a term, means removing fibroids. There are different types of myomectomy. Some are more invasive than others. So you have open myomectomy, right, with a kind of a C-section cut here, or even a big up and down incision. And then there's robotic myomectomy that requires multiple incisions and sort of the semicircle in the middle of the abdomen. This is the belly button. This is with the same, you know, with the ports inserted. And then there's the lamb procedure, which is kind of a hybrid procedure. It's a combination of both. So we're using small incision at the belly button and then a little bit larger incision in the bikini line, but still very small. So this is about 1.5 inches. Because open incision is obviously a big incision, right? You're going to have a lot of pain. There's hospitalization. There's, you know, prolonged recovery, typically 6 to 8 weeks. With robotic, yes, the incisions are small, and yes, they're sort of not ideally placed for cosmetic purposes. But the problem with robotic is that with this approach, you're very limited as to how many fibers you can remove, the type of fibers you can remove, their location, and the size. With the lamb procedure, you kind of eliminate the limitations of open and robotic. You can do any location fibroid, any size fibroid with the lamb procedure, just like you would do it with open, but you have much smaller incisions. So you get the recovery of the minimally invasive surgery, but you can accomplish much more just like you would with an open incision. So think of it as a very tiny open incision and it really allows you to do a lot. So it's best option for patients who desire fertility. I'm not going to tell you it's the best option for somebody who doesn't want fertility, because there's still pain associated with the surgery. And sometimes patients who don't want fertility may have a better recovery going through what's called a dual port hysterectomy, or a minimally invasive removal of the uterus. But for fertility patients, this is perfect because you take out the fibroids, right? So you get rid of what's causing infertility. You have immediate results. So, you know, you have a watermelon fibroid, you take it out, watermelon's gone, right? So you no longer have the pressure, the back pain, the frequent urination. You do have to wait for the uterus to heal. So pregnancy, you can start trying to get pregnant within 6 months of the surgery. And that can sometimes vary depending on how many and where the fibroids were really located. And then, but the recovery from surgery is 10 to 14 days, and it's completely outpatient. The thing with outpatient surgery is that what a lot of patients don't realize is that if you do it in the hospital, so let's say you had your surgery in a hospital, but great, you went home the same day, you still have higher costs of the surgery because you have to pay hospital fees. So unless your insurance pays for everything at 100%, which is pretty unlikely, most patients will have some type of, you know, co-insurance. So it's their portion, their responsibility that they have to pay. And it's typically a percentage of the hospital fee. So because hospital fees are very high, your out-of-pocket is going to be much higher than if you did it in an outpatient facility. So it's something that a lot of people don't realize, but it's true. But so with the LAM, you can do it in an outpatient facility. You don't even have to do it in a hospital. You're going home the same day. And the techniques that are used during this procedure allow us to do it safely, even for big fibroids. So it's a really great option. Now,
hi, Dr.
Sure.
Can we take a question before we progress?
Yeah.
If we go back to the different procedures slide, yes, we have a question. How do you determine the number of incisions needed for laparoscopic myomectomy?
Yeah, so typically for the LAM procedure, we use 2 incisions. So it's the belly button incision, that one's for the camera. And so that one's, you know, always standard. You always need that one. And then the lower incision is through the incision through which the fibroids are going to come out. Sometimes, very rarely, but sometimes a 3rd incision on the side is necessary if there's extensive scarring from prior surgery. So some patients, unfortunately, you know, have more than one myomectomy, right? So they may have had fibroids in the past and had fibroid surgery in the past. And let's say they had open fibroid surgery and now fibroids came back and they're looking for something less invasive. So they may have extensive scar tissue, which sometimes requires another incision on the side that's could be 1/4 of an inch. So same size as this one, but it's on the side. But I would say 95 or more % of the time, it's just these 2 incisions.
And can we talk about the duration in terms of the procedure? So if someone is having a open surgery, robotic or LAM, what is the duration of the procedure itself?
Yeah. Yeah, so the duration is going to vary. So typically, historically, robotic surgeries take the longest, just because of the way it's done. Yeah, just the technique of it. It takes longer to take, let's say we're taking out 5 fibroids. It's going to take you significantly longer to take out 5 fibroids robotically versus open versus LAM. I mean, there's going to be some variation in terms of surgeon skill and all that, but a LAM procedure, average, I would say 1.5 hours. And then typically we're taking out more than 5 fibroids. You know, if it's 1 fibroid, it could take 40 minutes. So it's very fast. But robotic surgery can sometimes take 4 and 5 hours. Again, depending on the surgeon and how sort of slow or fast they're going and how many fibroids or how big the fibroid is.
Great. And we can take one more question and then we'll
Yeah.
take the rest at the end.
Yeah.
Will the incision be bigger if the fibroid is large with LAM? Could healing be longer than 10 to 14 days to feel normal, quote unquote normal?
Yeah. So the incision typically is doesn't have to be larger. It's the size of the fibroid doesn't dictate the size of the incision, because most of the time the fibroid is going to be much bigger than the incision. But what we do, we remove those fibroids in segments. So by removing it in a segment, I can take out a watermelon-sized fibroid through an incision that small. In some, rare instances, because the main thing with myomectomy is that we have to control the bleeding during the surgery. That's sort of the key. If you can't control the bleeding, you can't do anything, right? Because the uterus has a very good blood supply, and the bigger or more multiple fibroids are, the more blood flow there will be to those fibroids. And that's kind of the basis of the embolization, right? They're targeting the blood flow. But during myomectomy, we have to control that blood supply. Otherwise, there's going to be too much bleeding. You won't be able to get the procedure done, especially with small incision. So in order to control the bleeding, sometimes we may have to extend the incision if the fibroid or fibroids are in the place where we typically would go to control the bleeding. So depending on the location of the fibroids, for example, fibroids that are in the cervix or near the cervix tend to occupy space where blood supply comes into that area. And those procedures are a little bit more risky and have more potential for excessive bleeding. So we may extend the incision a little bit, but that is the beauty of the LAM procedure. The problem with robotic surgery is, let's say you are determined you're going to do it robotically. If you get into bleeding, you have to open. There's really no in between. With the LAM procedure, you already have a small open incision, right? So you're already essentially open. It's just a very tiny open. If you need to, we can extend the incision just a tiny bit. I mean, sometimes it's literally, just a quarter of an inch more, and then we can see better and control the bleeding better. It's not just going from a bunch of small incisions to big one, open one. So that's another advantage of the procedure.
Thank you. And I've shared a link to a video of like a procedure happening in real life, so you guys can check it out in your own time. And also, I see the questions that are coming in. We have allocated a lot of time at the end of the presentation, so please know that we're not ignoring the questions. Thank you.
All right, good. Yeah, and then if a lot of you are interested in looking at this article, you can definitely pull it up online, but it's a laparoscopic assisted myomectomy paper comparing to this procedure to other myomectomy procedures. And this was 1,300 patients. So we took 1,300 patients that underwent surgery at Holy Cross Hospital, which is in Silver Spring, Maryland, over a 2-year period. And some of these patients had open surgeries, some of these patients had minimally invasive surgeries. So we took all of those surgeries and looked at the complications, how long the surgery took, the blood loss, all these different parameters, and compared them. And what we found was that the LAM procedure had lower blood loss compared to other procedures. It had faster operative time and fewer complications, and more fibroids were removed. So, but to kind of, if you wanted more details, please, I encourage you to look at this paper. All right, so this is just, again, a recap comparing the LAM to other myomectomy type procedures. And again, as I mentioned before, robotic, right, is the longest, the one that takes the longest. Of course, the open procedure is going to have longest recovery. And then the pain, is going to be more, the bigger the incision. So any questions? So I think I'm done. I didn't want to go too much into detail, but I can, as kind of these questions come up, I will definitely be happy to explain more.
Yeah, this is perfect. We have some questions. Would you like me to read them to you, or would you prefer?
No, I can, yeah, I can read them. So
they're in the Q&A that are coming in.
Yeah, yeah.
And I encourage you all to, now is the time to ask your questions. So just keep them coming. We have half an hour to address any questions you might have.
All right, yeah, so the first question, I think I answered in terms of the incision, having to be bigger. Again, most of the time it does not need to be bigger for a bigger fibroid. Healing, everybody's different. So typically would say, most patients at 2 weeks, which is when I see patients for their post-op visit, most of them feel fine. They're not taking any pain medications. They might have discomfort here and there, but for the most part, they feel back to normal and ready to go back to work. Pain medications, typically first 3 to 4 days, you would be taking pain medications, but second week, most patients do not require any pain meds. So second question is, if I have submucosal fibroids, am I a candidate for embolization? Also, if I do myomectomy, will this lessen my percentage of infection with the type of fibroids I have? Yeah, so typically with uterine fibroid embolization, it's not ideal to do this procedure if you have a fibroid in the cavity. So submucosal can, it can mean a few different things. So you can have a submucosal fibroid that's entirely in the cavity. So if going to this picture, okay. All right, so so this one is submucosal, but it's only partly in the uterine cavity versus having a fibroid that's completely in the uterine cavity, like if all of it was in the uterine cavity. So if you had a fibroid in the uterine cavity, if you do embolization, you can have this fibroid die off and then try to, either gets infected and causes infection in the uterine cavity, or sort of detaches itself and then tries to abort itself through the cervix, which can be an extremely unpleasant experience. So embolization is not ideal for fibroids that are in the cavity. If you do a myomectomy, I mean, you just take them out. So you wouldn't really have to worry about having an infection of those fibroids. And depending on how big they are, I mean, you may be able to get away with doing a hysteroscopic myomectomy. So we don't even go through the abdomen, we just go through the cervix and take out these submucosal fibroids. But I'm assuming if embolization came into discussion that they're big. So I would recommend taking them out rather than embolizing. If I have already had open surgery, would you use the same incisions to take out fibroids? Yeah, so we use a portion of that incision, right? So we don't need to use that entire incision, the entire length, but we would use the middle of that horizontal incision to take out the fibroids. What is the criteria for the size and location of the fibroids for LAM or any other MIGS option, particularly if you had an open myomectomy over 6 years ago, removed over 30 fibroids? So the beauty of the LAM is that it really doesn't have any criteria. So you could have, 30 fibroids, or you could have 3 fibroids. They can be very big or they can be small, but within reason. So we always say, risks versus benefits. For any surgery, whether it's open or minimally invasive, there has to be more benefits than risks, right? So if you have, sometimes we see extreme cases, just enormous fibroids, and the uterus is up all the way to the chest bone. Is any myomectomy going to be a safe procedure for you? Probably not, all right? So when there's been that much delay in care, and when we're talking about something that extreme, that even if you have an open myomectomy, and that's probably the only type of myomectomy you would be able to do at that point, the risks are probably going to greatly outweigh any benefits, because at that point with fibroids that size, it's highly unlikely that you're going to be able to end up with the uterus that's suitable for fertility at all, because as the fibroids grow, they destroy the normal uterine tissue. So what you end up is with just something, but totally not functional. But within reason, the LAM procedure is great because again, regardless of the size, within reason, and number of fibroids, it can be done, or location of fibroids really doesn't matter. But if you've had prior surgery, there might be some scar tissue, but doesn't mean that LAM is not doable. It's still doable in most cases. What does it mean if your periods become unmanageable and you have too much bleeding? Well, it means that it's time to take care of the fibroids. If you do have fibroids, right? So you could have other causes of abnormal bleeding. It could be endometriosis of the muscle of the uterus. Precancerous or cancerous cells in the uterus can cause bleeding. So there's definitely, if there hasn't been any investigation, you should get a pelvic ultrasound and possibly a biopsy of the uterine lining, and really figure out what's causing the bleeding. And, but typically surgical management is required to address it. All right, what does it mean if you have a really big fibroid, and what feels like your kidneys are hurting? Well, so, normal uterine size is about this big. I don't know if you can see it. Yeah, there you go. So very small. You can't feel the uterus, normal uterus. It sits behind your pubic bone. So if you can feel your uterus, that's a problem. That means you have, something growing in there. And if you're not pregnant, it's likely fibroids. So if your fibroids are large, they're going to start pressing on other structures. So your bladder sits in the front of the uterus at the bottom. So you could have frequent urination or pressure and sort of urgency to urinate. Your uterus can start pressing on your back. And if you're referring to like flank pain, kidneys hurting, you could have, if the uterus is that large, it can be pressing on your mid back even. You can also have what's called hydronephrosis, or actual dilation of the kidneys, because the large fibroid or fibroids are compressing the ureters, which are tubes that go from the kidneys to the bladder. And by blocking those tubes, the kidneys swell up, which can cause permanent damage to the kidneys if not addressed. How long is the wait to schedule a procedure? You booked until 24. Yeah. So this is funny. It's not funny, but it's interesting because, sometimes I see patients and they say, oh, I wanted to see the specialist, but their first appointment is, 3 or 4 months from now. Our practice is different. We're all full-time practitioners. There are some doctors out there who, go around traveling and giving lectures on the procedures that they do. And then they might maybe see patients once a week or maybe once every 2 weeks. So we all full-time surgery. Okay. So all we do is we see patients in the office for a consultation, or we do phone consultations, and then we do surgery. So we do operate typically about 3 days a week. So we can get you in very quickly, because our, again, main goal, our main function is to do surgeries and treat fibroids. So we're not booked until 2024. We can get you in pretty quickly. And also because we're dealing with outpatient surgical center and not the hospital, we don't have to sort of stand in line, right? Because that's what happens to a lot of doctors, is that they might have 1 day a month that's dedicated to surgery. So, very quickly that 1 day gets booked. Also, because LAM procedure is much more efficient than robotic, we can do multiple surgeries in 1 day rather than 1 or 2. So we can definitely get you in much faster.
Yeah, and on that note, if you're interested in scheduling a consultation, I have shared a link in the chat box. So like Dr. Danilyants said, it's as easy as just going into that link and scheduling a consultation. So that resource is right in the chat box for you.
All right, good. All right, if you no longer want to preserve fertility, when is it time to do a hysterectomy versus myomectomy? Great question. It comes up all the time. So, when you trying to get pregnant, that's pretty clear, right? Your only option is a myomectomy. You have to take out the fibroids. All you have to do is just sort of figure out what type of myomectomy. you're going to do. If you're not desiring fertility, then realistically, you have, then now multiple options, right? You can do embolization, you can do hysterectomy, you can do myomectomy, you can do the Acessa procedure. Then it really comes down to what's going to give you the best results and what's going to have the lowest complications. So usually, and I always tell this to patients, most of the time, especially when we're dealing with multiple and large fibroids, myomectomy is going to be a riskier option than a hysterectomy because there's more potential for bleeding during the surgery and after the surgery because you're cutting into the uterus, you're taking out these fibroids, you're sewing the uterus back together. And so all of those areas where the fibroids were removed can bleed. And then there's more pain, right? Because you're just beat up the uterus and then you're going home. So there's a lot of pain, not just from the incisions, but from the uterus itself. With the hysterectomy, you're just taking out the whole uterus. So it doesn't matter if you have, 50 fibroids in there. Yeah, your recovery is going to be very similar to somebody who had, 5 fibroids. There's less risk of bleeding because, again, you're not having to repair the uterus. And there's less pain. Really, most of the pain is just from the incisions. And the incisions are also small. So one incision at the top of the belly button, which is 1/4 of an inch, very similar to the lamb procedure. So, and a lot of patients think that hysterectomy means like, oh, I'm going into menopause right after the surgery. No. If you're young, we keep your ovaries, right? So the ovaries will continue to produce hormones. We keep the cervix for pelvic floor support. So it just like not every myomectomy is the same, not every hysterectomy is the same. So sometimes you just really have to understand, what is involved with this procedure and what you could expect. Because the beauty of hysterectomy is that you don't have to worry about fibroids coming back, right? And then having to, in 5 years or 10 years or 6 years, have another surgery. You're done with these fibroids. So if fertility is not desired, I think hysterectomy is going to be the best option. Embolization is only going to be an option if the fibroids are small, right? But if they're big, you're not going to be happy with the results. Now, can a fibroid be confirmed via scans, or is removal the only way to determine that it's not malignant? Technically, there is really no way to tell that a fibroid is just a fibroid by imaging. Sometimes on MRI, if it looks very sort of like it's dying off and degenerated and uneven colored, there can be sometimes suspicion for malignancy, but it's certainly not diagnostic. So you can't, with 100% certainty, get an MRI and say, oh, this is cancer, this is not cancer. No, the only way to know would be to remove it. But thankfully, most fibroids that are identified as fibroids on imaging are just that, they're fibroids. But if something is, increasing very rapidly, again, not diagnostic for cancer, but, if something growing very fast, we always get concerned. And that's another reason to remove it and not just do embolization. How likely is it for the fibroid to come back after a lamb procedure? I would say as likely as after any procedure where you're removing a fibroid. So it depends on age. The younger you are, the higher there is risk of fibroids coming back, just because fibroids are hormone dependent. Can a fibroid come back in somebody who's 65? Well, no, because they're postmenopausal. They're not producing hormones necessary to grow fibroids. Estrogen is the hormone. But if you're 20 years old and you had a myomectomy, I would tell you that most likely 99% likelihood that you're going to need another surgery in the future for fibroids. Multiple fibroids, so when a patient has had multiple fibroids removed, their risk of recurrence is higher. The thought is that probably they have a lot of little seedling fibroids, little tiny fibroids all throughout the uterus, and those will just continue to grow. And sometimes, at the time of the surgery, when we find all these fibroids, I tell patients, okay, you have a very high risk of recurrence. And sometimes that's the reason when we may not choose to do a myomectomy, right? We might say, okay, you have innumerable fibroids seen on imaging, on ultrasound or MRI. Does it really make sense to do a fibroid removal when they're just going to come back in a few years if you're not planning on using the uterus for fertility? What's recommended for a hysterectomy, especially for someone who already had 2 myomectomies? Do you see international patients for LAM? I would say, and I mean, I don't want to generalize. So I'm assuming these were 2 abdominal myomectomies, right? So let's say if somebody who had 2 hysteroscopic myomectomies, would I do, which is when we're going through the vagina to take out a fibroid inside the cavity. I don't really count those so much, because when you go through the abdomen and you cut out fibroids, that leads to scar tissue. So 2 prior abdominal myomectomies are going to likely result in significant scar tissue. And doing a 3rd one is going to be pretty difficult. So you're going to have risk of infection, higher risk of bleeding, higher risk of uterus not healing well. And, when it comes to fertility, I would probably tell the patient, and again, there's going to be exceptions, but after a 3rd myomectomy, it would probably be terribly unsafe to get pregnant, because the uterus has been cut and repaired, too many times. It's like, a pair of socks. Let's say you have a hole on the heel, and then you sew it up, and then you wear it and it rips again, and you sew it again, and it rips again. I mean, it just, the integrity of the tissue is not there anymore, because you keep repairing the same tissue over and over again. So it probably, again, there are going to be exceptions, but generally it wouldn't make sense to do a 3rd myomectomy. And a partial hysterectomy is going to be much more rational to do. So removing just the uterus, leaving the tube, and leaving, sorry, not the tubes, leaving the ovaries and leaving the cervix. And yeah, we do see international patients that travel, and then we do a phone consultation typically, and then they travel for surgery and then travel back either a few days or maybe a week later, depending on how far they're going. All right, let's see how much time. Let's see, I have a current 3 centimeter scar from a type of LAM surgery to remove fibroids. With now new fibroids present, would I need a C-section if I were to ever get pregnant? So the need for a C-section is not dependent on the scar on the skin, but it depends on from what portion of the uterus the fibroids were removed. So if you have, let me go back to my picture here. So let's say you had a fibroid, you had a LAM procedure that was, with the 3 centimeters, and you had this fibroid removed, the one that's hanging off the uterus. You would not need a C-section, because you have not cut into the uterine muscle. And so you can go through labor, which means you can have the uterus contract in labor, and you wouldn't have to worry about the uterine muscle tearing up or separating. If you had, let's say, this fibroid removed or this fibroid removed, and how it would be done is we had to cut through the muscle of the uterus, and remove this fibroid, and then stitch the uterus back together, cut through the muscle of the uterus, take out fibroid, and then stitch the muscle back together. If you went into labor and that uterine muscle was contracting, the area where the muscle was sewn can separate or rupture. We call it uterine rupture. So that would be extremely terrible and very dangerous, and you could die and potentially also lose the baby. So that is why when on most myomectomies, because in most cases, you're going to have combination of fibroids throughout the uterus, not just one hanging on the outside. Most cases will recommend that a C-section is done, not a vaginal delivery. So I would say check with your doctor. I mean, if you had the LAM procedure with us, you just make sure that, you talk to somebody and find out if you could have a C-section, or if you need a C-section or not. Will pregnancy or becoming pregnant shrink or starve the blood supply to the uterus? So it doesn't shrink or starve the blood supply to the uterus, but to the fibroids, I think you meant. So yes, so when you're pregnant, during pregnancy, there are two things happening. One, there's changes in blood flow and where the blood supply is directed, which is to the placenta and the baby. But also there's changes in hormones. So sometimes those changes in hormones can lead to fast increase in the fibroid size. But then they sort of undergo what's called degeneration. So they start to die off. So if you already have big fibroid, I would say don't think of pregnancy as like, oh, it's going to treat my fibroids. Think of it as it might potentially cause a major issue because that fibroid could get even bigger. And yes, in the end, it'll probably start to die off and shrink, but what sort of complication could it cause? You know, could it cause preterm labor? Could it cause severe pain? But in general, you know, if you have small fibroids, typically your OBGYN will follow those fibroids during pregnancy. And then, keep in mind that they can get bigger. And then typically after pregnancy, they get smaller. Can you have what feels like flare-ups? I look 6 months pregnant someday, but not all. Yes, so typically around period time, it is not uncommon for the uterus to feel larger. But I would say, 6 months, that's pretty significant. So you should definitely consider doing something about them. But yeah, this can be cyclical, and sometimes you can look bigger than others times. Is it normal to start depot shot for fibroids and my menstruation hasn't stopped in 4 months? My flow is not as heavy, just not stopping. Yeah, so this is what I mentioned in the beginning, like birth control pills, it's not really considered treatment. Yes, Depo-Provera, so it's a progesterone-only injection that's administered typically every 3 months. It's not a treatment for fibroids, it's just to sort of temporize some of the bleeding. But because the fibroids are causing the bleeding, the Depo may not stop your periods completely, right? It may slow them down or lighten them because it thins out your lining. But because it's the fibroid, for example, here, the submucosal fibroid is pushing up on this lining, which is what sheds every month with your period, then your bleeding becomes more sporadic or it could be constant. So again, that's just a sign that you need intervention, right? Rather than just Depo-Provera. Could patients wake up with an unintended hysterectomy after LAM? What is the chance of this? So hysterectomy at the time of any myomectomy is extremely rare. Patients, often when I see patients right before going into surgery, a lot of them sort of remind me, I want to preserve my uterus. And I say, yes, of course, I know this is why we're doing a myomectomy, right? So when we do the surgery, the key is to have an experienced surgeon, because an experienced surgeon knows kind of how to prevent complications and how to handle complications, and knows how not to let things get out of hand. Of course, there are complications, possible in any, in the most sort of, in the best of hands, right? But the more skilled or experienced surgeon is, the more they're likely to handle things without getting to a hysterectomy. So with the myomectomies, as I mentioned, bleeding is the biggest risk, right? Especially with very big fibroids. So that's why sometimes I will look, at an imaging report, and I see this really, really, really massive uterus with massive, massive fibroids, and I will tell the patient, I wouldn't even do it. The reason for this is because we don't want to end up with an unintended hysterectomy. That would be terrible. So one thing is to not do the surgery at all, because it's probably the wrong surgery. But otherwise, we control the bleeding with tourniquet, or we can even cut, or not cut, but tie off some of the blood vessels to control the bleeding. So there are techniques that advanced surgeons will know to avoid a hysterectomy. And sometimes it could mean what's called aborting the surgery. So in rare cases, if, I couldn't predict this prior to surgery, but if I go in and laparoscopically, and let's say this patient had previous surgery and they have scar tissue, which we knew they had previous surgery, but we do not know the extent of scar tissue. And let's say we go in and we see terrible scarring, and I can tell, again, from my experience, that if I attempt to do the surgery, this is going to be very complicated and potentially result in hysterectomy. So that's when we abort the case. Does that happen? I would say maybe once a year, or maybe more even rare than that. So it's extremely, extremely rare. But that's, again, there's risks with every surgery. Our goal to minimize the risk as much as possible. So a hysterectomy at the time of LAM would be extremely highly unlikely. It would be more likely to just terminate, to end the procedure. How likely the fibroids will become cancerous if untreated? So fibroids, and sorry, I'm going to plug my computer in because it's dying. So fibroids are not cancerous, so at all. So they don't become cancerous, but there are types of cancers that can look like fibroids on imaging. So as I was saying earlier, sometimes we do, we follow them, let's say, with another imaging. So if there's a fibroid that's growing extremely fast, right, that could be concerning. Sometimes on MRI, it can have certain characteristics, but generally, if it's a benign fibroid, it's always going to be benign, no matter how long you leave it. Does fibroid risk or concern decrease with menopause? Yes. So, if you are 50 years old and you have fibroids, and let's say you do imaging and they're small, I just actually saw someone the other day. So she said, I don't have any symptoms, but I had an ultrasound and they saw fibroids. Do I need to have surgery? And these fibroids are small, like 2 to 3 centimeters. And I said, no, there's no periods anymore, right? So there's no bleeding, there are no pressure symptoms. I mean, absolutely 0 symptoms, and the fibroids are small. You don't have to do anything. They're not going to grow. They're going to stay the same size. They've probably been already there for, past 5-10 years. So it's a non-issue. So typically, if they're small, it's not a problem. But if they're large and they could be causing some pressure symptoms, even though the periods are not there anymore, you may still have to address it.
Dr. D, can we switch to the chat box now? We have questions that were coming in also simultaneously. So I want to make sure we address some of them as well. Just in the interest of time, I want to make sure these questions that came in earlier. So Alexis, we have, do you take out-of-state patients? I live in PA.
Yes, we do take out-of-state patients, absolutely.
And then what is the conversion rate from LAM to an open myomectomy?
Yeah, so we have 0 conversion rate because, as I mentioned earlier, with the LAM procedure, because of that low incision, that tiny open incision, we can always extend it just a little bit to give us enough room or to better control the bleeding without having to, open completely, because it's already a small open incision.
What are the sizes of fibroids that you have to be worried about? I have a 6 centimeter fibroid. Do I need to do a myomectomy?
So typically a 6 centimeter fibroid is sizable. So it's something that definitely needs to be considered, because the issue is, unless you're already in menopause and we think that the fiber is not going to grow, the issue is that they grow over time, right? So a 6 is going to become a 7, an 8, and 10, and when do you stop? So it's not a matter of if you have to do it, it's when. And the smaller the fibroid, the less complicated the surgery. So I would say you're going to have to take care of it some point. Might as well just do it now and get it over.
Great. Can you speak on the recovery of hysterectomy? I think we talked about this already. Recovery,
it's about 7 to 10 days. Yeah.
What is the criteria for the size and location of a fibroid for a LAM or any other MIGS option?
Yeah, so for the LAM, we don't have any criteria for the size. So you can do it. They can be very large or small, and the location doesn't matter. For robotic and standard laparoscopic, the size, location, and number absolutely matter. So the larger or the more numerous the fibroids, the less likely it is to be accomplished robotically.
Okay, I think we can now switch to the Q&A.
Okay, all right. So I think I've only have 3 questions here remaining. So I had fibroids removed in 2010, had a C-section in 2012, had few fibroids removed during that time. The fibroids did grow back. I feel 2 of them on my lower right side of the stomach. I'm anemic, going through perimenopause, done with having kids. I am not interested in having a long recovery. What would be recommended in my case? Thanks. I would recommend doing a dual port, a 2-incision hysterectomy. So you could keep your cervix. If you want to keep the ovaries, you can. It would be a much faster recovery than a LAM procedure, but still keeping small incisions, outpatient surgery. Yeah, I mean, it's going to be the least invasive and best recovery. So, yeah.
Okay, so the chat, do you see the chat, Dr. D? If you click on the chats.
Yeah. Oh, wait, hold on. Let me just do these 2. So I have 12 plus centimeter in the uterine wall. Is there concern even for LAM? Yeah, so you can do a 12 centimeter fibroid that's in the wall of the uterus with LAM. That's not a problem. What is the cost for the LAM procedure? So we use your insurance. If you do have, if you don't have insurance and doing self-pay, we have financial counselors that can give you a full estimate. Where do I go for? I'm in the chat, so do I just go away to the top?
You should be able to see the questions. Do you see them?
Yeah. I just don't know where we left off.
So we left off at M. What is the criteria for size and location? We've addressed that. We are at Janet, I believe. Janet Benjamin. I've had a LAM myomectomy.
Yeah, what is the size? Where can you speak on recovery? Yeah, so recovery. Yeah, what's the criteria for the size? We did that. Okay, I truly value your knowledge. I've had LAM myomectomy, removed 33 fibers endometriosis with varying sizes. Largest was 13 by 13, and I was a travel patient. I was able to successfully carry to 2 full-term pregnancies after, thanks to you guys. Congratulations. That's great. That's great. Yeah, I mean, that's amazing. But, you know, the key here I want to stress is that, you know, if you desire fertility, age is really important. Okay. So because, you know, I'm going to pat myself on the back for taking out all these fibroids, but had, Jen had been older, right, it may not have been possible because then age becomes a factor, right? Because so we're just working with the uterus and we're kind of putting it back together and make it as best as possible to carry a pregnancy, but the ovarian function has to be there, right? The quality of the eggs and the number of the eggs that comes with, you know, young age.
So she does have a question in there. If you,
Yeah.
My concern or question is that I have 1 ovary left. So if you can.
Oh, okay. So yeah, so my concern or question is I have 1 ovary left. So if the ovary is all that remains for estrogen, what does the hormone replacement procedure look like? Yeah, I mean, whether you're taking out that last ovary at the time of the hysterectomy, or if you're going through, you know, just natural menopause, or you're leaving the ovary, you do estrogen replacement. All right. So if you're doing a hysterectomy, you don't have to worry about, you know, increase of uterine cancer with estrogen only. You don't have to go on combination hormone replacement and worry about increase in breast cancer. So estrogen only therapy, if your uterus is gone, is extremely safe, and you just go on low dose. So whether you keep that 1 ovary or not, it doesn't matter. You just do estrogen replacement. All right. So what are the chances of accidental bowel injury with the LAM procedure? So it's very rare, but with any surgery, it can happen, right? Because you have bowels located near the uterus, you have bladder located near the uterus. So especially if there's scar tissue, whether it could be from prior surgery, it could be from prior infection, it could be from endometriosis. And the trick with scar tissue is that we don't know that it's there, right? So before the surgery, we can have imaging, we have an idea of the size of the fibroids, how many there are about, right? But we don't know if there's going to be scar tissue. we can guess it. If somebody who had prior, open myomectomy or 2 myomectomies, I'm going to assume that there's probably going to be pretty terrible scar tissue. But with no prior surgeries, it's impossible to tell. So then it's only during surgery that we discover, okay, there's scar tissue. And so scar tissue involving the intestines can increase the risk of bowel injury, and especially unrecognized bowel injury. Okay, good. Let's see. What is the average cost for the procedure? Okay, yeah. So we have financial counselors, so you can definitely email us, and we'll give you an estimate if you do not have insurance. But we are in network with most commercial insurances. And let's see, it's due to. Yeah. So we have. So we operate out of Maryland and New Jersey. So those are the two surgical surgery centers, outpatient surgery centers that we operate out of. I've been recommended an ablation. What are your thoughts? So ablation is not a treatment for fibroids. It's burning of the uterine lining, which you can potentially do for very tiny fibroids in the lining. But if you have any sizable fibroids, I'm going to say it's going to be pretty much of a waste of procedure. So you definitely need to talk to someone else to figure out if that's the right thing to do. Oh, I lost. Oh, do your office do hysterectomies? Yeah, we do hysterectomies, minimally invasive, 2-port hysterectomies, which are extremely effective. Oh, you already answered. Okay. I have small fibroid, can't remember the size, and still have anemia problems. Ablation was recommended. What is the difference in 3 procedures? Yeah, so ablation potentially can be okay for tiny, tiny fibroids in the uterine cavity. But so it's like this one, but much smaller. It's just burning of the entire lining of the uterus. But if you have large fibroids, I would say don't waste your time. I think.
Thank you so much. That was right on time. 1 o'clock. It is 1. Thank you. These were excellent questions. Thank you for really bringing in and engaging with us. And as I mentioned at the beginning of the webinar, I'll send this recording as a resource, as well as the PowerPoint. I shared the article that Dr. D talked about in the chat box, but I'll also share it in my email. And then please take a moment to complete the evaluation. It will take you just a minute, but it helps us improve these programs. So thank you all for joining us, and I hope you have a wonderful rest of your day. I'll stay on for a bit for you to go ahead and complete that evaluation. But Dr. D, I'll connect with you offline, so you can.
Okay. All right, thank you.
Bye.
Thanks, everybody. Bye. Bye.
Great. Samantha, we'll send the recording in an email. So if you're part of our email list, I'll go ahead and send it to you. Perfect. Thank you for I'm gonna make a note of it. Thank you. Yep, I'll be sending out the recordings to everyone that was present today. So right, I think that's ample time for you all to complete the eval. Have a good day. I'm gonna go ahead and end this webinar.